afternoon. Thank you to all my colleagues attending their Hepato Pernambuco 2020 Liver Talks webinar. It's my great pleasure to have my friends, Professor Henegan and Dr. Deepak Joshi from King's College, London. For now, I'd like to introduce my co-chair, is a Professor Dvora. She's Associate Professor from University Federal of Rio Grande do Sul. We will be starting to introduce my speakers, international speakers. Is Michael Henegan. He's a consultant hepatology and professor of hepatology from the Institute of Liver Study, King's College Hospital, United Kingdom. And Dr. Deepak Joshi, he's a consultant hepatologist at the Institute of Liver Studies at King's College Hospital, also from United Kingdom. Both of them, we are going to talk about autoimmune hepatitis and primary sclerosing cholangitis. From now, before we start the talks, I'd like to invite the Professor Michael Henegan, that he going to, he prepare a small tribute to my eternal professor, Dr. Roger Williams. Welcome to our meeting, Professor and my friend, Henegan, please.
So thank you so much for the invitation to speak to this meeting. And it's a real pleasure. That I actually began to get to know Roger when I started attending the Hepato Pernambuco meeting. And you have been showing various photographs in the background. I'll just tell you a little bit of Roger's life. Roger came originally to King's College Hospital in 1966. He had a background actually in asbestosis of the lungs. That's what he did his doctorate thesis in. So he really was a lung doctor or a chest doctor, but he spent time working with Sheila Sherlock. And when he came to King's, all he had was a desk and a chair. He didn't have an office. He had nothing. And he set up the liver unit in 1966. He said it was about 5 months before he could do a liver biopsy. But in 1968, he started liver transplantation in the United Kingdom with Sir Roy Khan, who is right beside him on the left-hand side, smaller man. And you can see at a meeting Tom Starzl. Roger Williams was the father of transplant hepatology. Without him, we would not have the specialty of liver transplantation medicine, and Roger was the founder of this. Roger spent 30 years at King's, then spent 20 years at University College London, came back to us in 2016. At this point, King's liver unit was 50 years old, and Roger built the Institute of Hepatology, cost £5.5 million, but it houses 50 scientists, all dedicated to the study of hepatology and particularly liver biology. This is Roger throughout his career. 1972. I'm choosing 1972 as an interesting year. This was the year in which he contributed to the Childs-Pugh classification of liver disease, transection of the esophagus in patients with cirrhosis. And this helped stratify patients with liver disease from the very beginning. He was involved in setting up endoscopy at King's. This is 1989 when he was getting a supply of Prograf or tacrolimus FK506 in some of the original studies. And 2019, that's a photograph I took last year of him in the Institute of Hepatology, and certainly he was ruling the roost. His contributions to liver medicine span every single disease, from autoimmune hepatitis to viral hepatitis. And I see that Ed Gain is also speaking in one of your meetings. Roger was a great friend to Brazil, and he believed in having people from all over the world be in the Institute. Diversity was what made Roger and his vision so important. The mix of people was the key. I've chosen some pictures of some of his disciples, some of Roger's old boys and girls. Don Jensen from Chicago, Vicente Arroyo, one of the kings of portal hypertension. Will Lee from the USA, from Dallas, acute liver failure. Michael Lucy, one of the kings of alcohol-related liver disease and transplantation. Julia Wendon, liver critical care, helped develop the specialty because of Roger. Willis Madry's discriminant function. John O'Grady, the O'Grady criteria. James Newberger, PBC and transplantation. Rajiv Jalan, acute and chronic liver failure. And of course, Ed Gain, who described so much about the biology of hepatitis C and how it behaves after transplant. But all of these were his disciples, are his disciples, and they also have trained generations. The Foundation for Liver Research is the charity that supports the work, the science that Roger has contributed to in the last 25 years of his life. And he has over 40 scientists still working in the Institute. Brazil and football, well, Pele thought this guy was a good football player, George Best, and Roger gained a degree of notoriety as a consequence of transplanting George for alcohol-related cirrhosis. But actually what it did was it allowed the profile of liver disease to be expanded globally. Roger was more than a hepatologist. He was a sailor, and it wasn't unusual for the fellows to have to go down and help crew the boat. He loved the opera. This is his wife, Stephanie, who I think I met for the first time in Porto de Galinas when Roger came to the meeting, and these are some of his family. This is him as a farmer on his tractor on the farm in Wiltshire. His legacy is not the people, just the patients that he has treated or the people that he has taught in relation to liver medicine. He has highlighted the disaster of liver disease in the United Kingdom and also in Europe. I think Roger's legacy will be intact, and I'm often reminded of greatness by this phrase. It was in relation to, or was said by a previous British Prime Minister, when he said that the legacy of heroes is the memory of a great name and the inheritance of a great example. So Roger, he meant a lot to us all, especially to you, Leila, and none of us would be, I think, interested in hepatology if we hadn't the influence of Roger in this setting.
Okay, Mike, thank you very much indeed. You're very precise to the Roger memories. I have only 2 slides, and I apologize to speak Portuguese now to my friends in Brazil, that I have a very good experience with Roger for the last 7 years that I spent in the King's College and also in the Cromwell Hospital, when you have set up his private outpatients clinic. Eu tenho uma grande satisfação de falar um pouco sobre o professor Roger Williams e do que ele representou na minha vida, né, e o que ele representa para o Brasil, já que o Michael já fez uma grande exposição, o que significa o professor Roger Williams na hepatologia mundial. Eu posso dizer a vocês que durante todos esses anos que eu passei no King's, o Roger era não só essa pessoa alta, com voz grossa, né, que muitas vezes amedrontava as pessoas, mas era muito agregador, incentivador dos jovens, o que me fez me inspirar para o que eu sou hoje na minha vida acadêmica. Então, o professor Roger Williams, além de ter sido meu co-orientador na minha tese de PhD na Inglaterra, ele se tornou um amigo. Vocês vão ver que aqui ele veio para, como o Mike falou, ele veio para Porto de Galinhas, ele veio para algumas vezes para o Hepato Pernambuco. Essa é uma foto marcante que eu mostrei para vocês aqui, ele com o Stefan, que veio com a esposa dele, junto com a minha família. Então, nós convivíamos já com essa parceria. O Roger sempre foi um grande incentivador, né, da pesquisa, me mostrou o que é ser um Research Fellow, né, para depois ser um estudante de doutorado. E, finalmente, eu tive o grande prazer, depois de ter voltado para o Brasil, retornei para Londres, onde fiz o meu pós-doutorado, e depois o Roger me convidou para que eu fosse um visiting professor, né, com a permissão de exercer a medicina na Inglaterra, e eu tive o prazer de dividir com ele, no Cromwell Hospital, a sua clínica privada, onde eu passei por 3 anos. Eu ia do Brasil para a Inglaterra ver os doentes junto ao Roger nas suas férias. E isso me deu uma grande oportunidade de exercer a medicina propriamente dita na Inglaterra, conhecer um mundo diferente, o incentivador do que ele foi para que eu criasse o nosso Instituto do Fígado e Transplante aqui em Pernambuco, essa parceria que ele tinha com instituições privadas, instituições de grandes empresários do mundo afora. E também tive a oportunidade de dividir com alguns colegas que fazem parte da Sociedade Brasileira de Hepatologia, que também foram seus fellows, como o professor El7, como o professor Hepato Pernambuco, que são membros da nossa Sociedade Brasileira de Hepatologia, e outros vários colegas que, em tempos menores, também tiveram a oportunidade de visitar essa instituição, de que quando eu cheguei, não só apenas, era a Liver Unit e se tornou o Institute of Liver Studies, hoje tão conhecido no mundo. Então, é com grande pesar e com grande satisfação que eu agradeço ao professor Roger Williams toda a parte da minha formação, e em nome dos meus colegas brasileiros, Michael Henegan, I say thank you very much indeed to present Roger Williams' memories to our Brazilian society in hepatology. Thank you very much indeed. Now, I invite you to start your talks from autoimmune hepatitis.
So I'd like to talk about treatment of autoimmune hepatitis in 2020. I'm not going to talk very much about diagnostics in the 15-20 minute talk, but just to really say that this is a chameleon disease. For the trainees in the audience, this is a disorder that is certainly can present at any age in multiple different ways of presentation, which makes it very difficult for clinicians, because some patients will present without any symptoms, some will have acute jaundice, cirrhosis, and some patients will present with liver failure. So just to restart, I apologize. This is a chameleon disease, has multiple ways of presenting. Patients may be completely asymptomatic to present with cirrhosis, acute liver failure, or indeed may present with acute jaundice. Now, ultimately, the goal of treatment is to try and deal with the inflammation, have recovery in the liver, but untreated, this is a condition that progresses to either death or a need for liver transplantation. This is a paradigm that we have proposed earlier this past 12 months, where we have broken hepatitis into its different phases. Patients who will present with acute autoimmune hepatitis with jaundice, no coagulopathy of significance or encephalopathy. Acute severe autoimmune hepatitis patients who present with jaundice but coagulopathy greater than 1.5 and with acute liver failure where they develop encephalopathy. Now, of course, there are patients who develop decompensated liver disease and may have acute on chronic liver failure. So there is a full spectrum of disease that we see with this condition. So making the diagnosis can be quite difficult. Autoimmune hepatitis is one of the few liver diseases where liver biopsy is still mandatory in the making the diagnosis, along with the characteristic autoantibodies and indeed the characteristic biochemistry. Now, why do we treat patients with autoimmune hepatitis? Well, this is a study, speaking of Roger Williams and his great mentor, Sheila Sherlock, steroids versus no treatment in autoimmune hepatitis over a period of 10 years. Steroids clearly impact upon survival. So this is why we actually treat patients, because if they're untreated, they die. Standard therapy in 2020 is very much about getting remission or obtaining biochemical and histological response with corticosteroids, either prednisolone 0.5 to 1 milligram per kilogram, followed by the addition of azathioprine after 2 weeks. That's the first line treatment recommendation from EASL. And again, some advice in relation to azathioprine dosing and how it is done. The presence of cirrhosis at onset of disease clearly impacts upon survival both at 5 years and at 10 years, with a clear variance in survival. Data from the Mayo Clinic originally suggested that cirrhosis was not a major impactor on survival, but that is indeed not the case. And of course, this is data from Sheffield, from Dermot Gleeson's group, where again, the predictors of outcome long-term are the presence of decompensation at any time, whether or not you have cirrhosis, and actually very important, failure to normalize ALT within 12 months. So looking at this biochemical response is critical. Also understanding that stability is the key to success in autoimmune hepatitis. The more relapses, the more flares, or the more lack of responsiveness in the disease, you're more likely to have significant complications, death or liver transplantation. Following on from this, actually, we're aware that budesonide, essentially a topical corticosteroid, is also of relevance, starting at a dose of either 6 or 9 milligrams daily, useful in non-cirrhotic patients, but again, reduce according to response, again, using the same paradigm of adding azathioprine. And these are the data that support the use of budesonide compared to the use of regular prednisolone. And I would bring your attention to panel D, where the use of the difference between the use of budesonide and prednisolone in patients who are either very in having a relapse or alternatively fresh patients with the disease, it actually favors the use of budesonide, with more patients having a remission within, or normal AST, ALT within 6 months, higher numbers with budesonide compared to standard prednisolone, and actually at even if you look at the surrogate of ALT activity, less than twice the upper limit of normal at 6 months, it seems to favor the use of budesonide. But remember, it's non-cirrhotic patients that you have to treat. One of the controversies that has been answered in the past 12 months is the fact that if you use doses of steroids, 40 milligrams to begin with, or more traditional Germanic dosing of 60, 80 milligrams, actually you do not achieve better results over a 6-month period, either with AST, ALT, or indeed IgG using higher doses. So there is no reason to be using higher doses of steroid therapy above 40 milligrams a day. And in fact, if you look at the remission rates, normal AST, ALT at 6 months, the best remission rates seem to be in this group of patients around 0.5 milligrams per kilogram. So there's no need to be pushing the dose up really high. And what is also notable is that once, of course, we know all of this, the higher you push the doses of corticosteroids, even if these results are not statistically significant, then we do not have, and we do not see any statistically significant dosing present. Also, something that is critically important is that if you treat patients, and this is the same cohort, a different paper from our group with the Dutch group just published this year, that actually if you get a good response to corticosteroid therapy, either prednisone or prednisolone at 8 weeks, the response at 8 weeks is also important in predicting the need for liver transplantation or patients who are going to have a liver-related death. So getting an AST drop of more than 80% within 8 weeks is a good marker of predicting survival. This is something that I think is very useful in the management of patients. These are the parameters, again, from this paper published this year. Even what is interesting, however, is that the more inflammatory your autoimmune hepatitis, the higher this is the ALT level above normal. So the greater the height of the AST, this is 20 times the upper limit of normal versus lower levels of AST, the more likely it is to have a better response. And similarly, patients who are more jaundiced with a more inflammatory phenotype of disease tend to do better. One of Professor Williams' long-term contributions to the field of autoimmune hepatitis, Phil Johnson, Ian McFarlane, Roger Williams, showed that maintenance treatment with azathioprine, long-term treatment, allowed you to withdraw corticosteroid therapy and maintain remission. And this was a major contribution to the field. What constitutes remission? It includes a liver biopsy that shows a reduction in inflammation. This is interface hepatitis and a huge lymphocytic infiltrate, no infiltration in the liver biopsy, hepatic activity index less than 3. The original definitions mandated also the resolution of symptoms, normal immunoglobulins in an inactive liver biopsy. Symptoms are probably not as important. How long to treat? Well, what we do know is that patients, and again, this is a study from King's in the early 1980s and a study from Holland in the last decade. Basically, once you withdraw treatment, patients are more likely to relapse. So even repeated studies, you only have 13 to 20% of patients who remain in remission 1 year after treatment. So this is very important data. What is also important increasingly is that treatment should be response-guided and individualized. So think about the patient, think about the side effect profile. And not everything that you think is autoimmune hepatitis. If you are in any doubt, you must reconsider the diagnosis and think about reinvestigating. If you have a patient who is not responding to standard treatment, and we think that up to 80 or 90% of patients should respond, question the diagnosis, question whether or not this is PBC or PSC, look for viruses, question the patient with regard to compliance, and then, if necessary, repeat the biopsy. And standard treatment of a flare is a trial of steroids, optimization of standard immunosuppression, then other agents. The concept of personalized medicine in autoimmune hepatitis is very important. Measuring metabolites is very helpful. A couple of studies, one from Sheffield, one from my time in the United States, certainly very helpful in looking at efficacy and toxicity, and certainly the concept of optimizing thiopurine metabolites using lower doses of azathioprine, but allopurinol when you have abnormal metabolite ratios is very important. So when you're thinking about alternative therapy in autoimmune hepatitis and the intensity of disease, think about the primary therapy that you're starting from, you're thinking about side effects, and you're also thinking about whether or not you're trying to prevent transplantation. So what are your options? Well, I've said that steroids, either oral or intravenous, to get remission, again, very helpful. Optimize thiopurine therapy. But after that, worth thinking about whether or not patients are better on budesonide if it's side effect related, mycophenolate, tacrolimus, CNIs. There is possibly a role for methotrexate, and in Holland, they're very keen on the use of thioguanine therapy. And these are our options in terms of trials. And there are trials running internationally from Novartis using an anti-BAFF inhibitor. There is interest in using interleukin-2, infliximab, and indeed rituximab. Real-life treatment, however, of difficult to treat disease is that mycophenolate is actually the drug. This is a survey from the International Autoimmune Hepatitis Group. Mycophenolate, tacrolimus, and cyclosporin. So what are the results? If you have somebody who has poorly active disease, this is real data taken from multiple centers. Group 1 are patients who become complete responders. So these are patients who either azathioprine or steroid intolerant. So basically being started on mycophenolate because of side effects. Well, those patients, you switch to mycophenolate, they do okay. If, on the other hand, these are patients with partially responsive disease or non-responsive disease, mycophenolate or Cellcept only works about 50% of the time or less. In contrast, if you are using tacrolimus as a treatment for partial response or non-response, it does appear that the treatment effects of tacrolimus are better. Although it's interesting, the recent AASLD guidelines suggest that they recommend MMF or tacrolimus in equal measure. I have personal views on that. What about the use of infliximab? This is data from Germany, from Ansgar Lose's group, where they used infliximab in patients with refractory autoimmune hepatitis, and they have shown that after 3 infusions of infliximab, transaminases improved and IgG also improved, and they're in the process of doing a clinical trial currently. The role of liver transplantation, important for patients with cirrhosis, end-stage liver disease, complications of cirrhosis, and acute autoimmune hepatitis. But remember, for giving long-term steroids in these patients for a prolonged period of time increases sepsis risk, and of course 20 to 25% of patients recur. Think about acute severe autoimmune hepatitis, patients with an INR greater than 1.5, 1.8. This is our experience. It's worth giving some of these patients a trial of steroids, but actually, if you have patients with a really high MELD score, they are still likely to require transplantation. Higher INRs, higher steroids are less likely to respond to steroids. So in 15 or 20 minutes, this is treatment of autoimmune hepatitis today. I would recommend a response-guided approach to treatment that is individualized, increasing experience with multiple agents. And what is important is that you identify transplant candidates early, don't over-immunosuppress them, and identifying true non-response is critical in the long term. So thank you so much for allowing me to participate, and we'll move on with the rest of the program.
Thank you very much indeed, Mike, for an excellent presentation. Now I'd like to invite Dvora to introduce the debaters.
I can't hear.
Obrigada, Leila. Eu queria agradecer por participar do Hepato Pernambuco, um evento de tanto sucesso. Parabéns por isso. Parabéns pela homenagem do professor Roger Williams e muito obrigada, professor Michael, pela excelente palestra. Eu tenho um prazer enorme em apresentar os debatedores dessa sessão, que são nossos queridos colegas professor Eduardo Cançado, nosso expert número 1 em doenças autoimunes e professor associado da Faculdade de Medicina da Universidade de São Paulo e médico do Hospital das Clínicas da USP. Também quero chamar um outro colega para debater, o professor Paulo Bittencourt, nosso dinâmico colega e ex-presidente da Sociedade Brasileira de Hepatologia e agilizador e presidente do Instituto Brasileiro do Fígado, coordenador da Unidade de Gastrohepatologia do Hospital Português da Bahia. Logo a seguir, a nossa querida colega, doutora Liliana Mendes, do Distrito Federal, colega do Grupo ECO, doutora em gastroenterologia pela USP, hepatologia do Hospital de Base do Distrito Federal e do Sírio-Libanês, hepatologista do Sírio-Libanês do Distrito Federal e também gastro e proctobiocardios. A Liliane vai nos apresentar o caso clínico a seguir, e eu vou deixar, então, para que se possa dar seguimento a este encontro.
Bom dia a todos, né? Gostaria de agradecer imensamente a oportunidade de estar aqui. Agradecer à professora Leila por esse convite e por esse evento, né? Que todos os anos eu espero como assim, um dos melhores eventos do ano. Cumprimentar o professor Henegan pela excelente apresentação. E o que me coube aqui é falar sobre um caso de hepatite autoimune do dia a dia dos nossos consultórios. Então, trata-se de uma menina de 19 anos, que natural e procedente de Brasília, que teve alta do ambulatório de gastropediatria na idade de 18 anos para o ambulatório de hepatologia de adulto.
Com licença, doutora Liliane, por favor, colocar sua compartilhamento da tela.
Uma moça de 19 anos, então, natural e procedente de Brasília, que teve alta do ambulatório de gastropediatria para o adulto, como a história diz, ter uma hepatite autoimune tipo 1 assintomática, com enzimas hepáticas normais nos últimos 2 anos, e no início do quadro, aos 9 anos, ela se apresentou com hepatite aguda ictérica. O exame físico era normal, IMC normal, e ela trazia a biópsia da data do diagnóstico de 2010, que era uma biópsia satisfatória, com uma fibrose 4 e uma atividade importante histológica, com periportal 2, atividade lobular 3, um infiltrado linfoplasmocítico e rosetas. Ela tinha um antimúsculo liso 1/320, com os padrões descritos como vascular, glomerular e tubular, usava micofenolato 2 gramas, prednisona 5, o sudeoxicólico ela estava numa dose aquém do esperado para uma CEP de pequenos ductos, e por não haver nenhum acometimento ductular nesta biópsia e na outra que a gente vai mostrar, a gente entendeu que a fosfatase alcalina fosse um fator confundidor pelo crescimento e optamos por retirar nessa primeira consulta e observar com 3 meses. Usava também reposição óssea para uma baixa densidade mineral. No nosso protocolo brasileiro, está descrito como a recaída ser considerada como um dos seguintes: o aumento de enzimas 2 vezes acima do normal, ou uma biópsia hepática mostrando a doença ativa, ou um retorno de sintomas acompanhados por elevação de enzimas que requerem um aumento na imunossupressão. Como que aconteceu essa situação na paciente? Em 2012, ela teve a ALT 2,8 vezes aumentada, foi aumentada a dose da prednisona e mantida a azatioprina. Em 2013, ela já teve um aumento mais considerável de ALT, então a azatioprina foi trocada pelo micofenolato e foi mantida a dose de prednisona. Em 2015, ela teve outra recaída, dessa vez de uma biópsia hepática, e foi aumentada a dose de prednisona para 7,5 miligramas. Então, assim, era uma criança, né, que estava mais ou menos aí por volta dos 40, 30 quilos nessas recaídas. 2015, outra recaída, foi aumentada a prednisona e o micofenolato para 1,5 gramas, e depois, em 2016, foi um aumento mais expressivo de enzimas hepatocelulares e chegou-se à dose de 2 gramas, que é a que ela usa hoje em dia. Nesse período de 2016 a 2018, ela persistiu com enzimas alteradas musculares e também TGO, e foi extensamente investigado e foi concluído que isso era devido ao uso crônico de corticoides, sem nenhuma doença de base. Nessa data, em 2010, eu fui voltando para a data do paciente, já existia a intenção de tentar fazer um passo a passo para essas respostas incompletas ou para falhas de tratamento, sendo inclusive considerado manter o uso indefinido da azatioprina como alternativa se o paciente não tivesse nenhuma piora com uma resposta incompleta. Nessa data também, o micofenolato e a ciclosporina eram ditos como as terapias empíricas mais largamente utilizadas e mais promissoras para tratar as recaídas e as não respostas. Em 2015 já se coloca mais robusto o micofenolato aqui em doses de 750 a 1 grama 2 vezes ao dia, como uma alternativa aos corticoides e azatioprina, mas também se colocam os anti-TNFs e os anti-CD20. Nessa data de 2015, a paciente teve essa biópsia, que era compatível com hepatite autoimune, com atividade inflamatória, com plasmócitos pseudoácidos. Os exames laboratoriais mostravam um FAM 1/640 nuclear homogêneo, um anti-músculo liso 1/40 sem descrever o padrão, o anti-LKM negativo e chamava atenção o cobre urinário, como a gente sabe que a hepatite autoimune pode mimetizar histologicamente, né? O Wilson pode se comportar histologicamente de forma parecida, foi extensamente investigado e não foi encontrado nenhuma situação que favorecesse o diagnóstico de Wilson. 3 meses depois da retirada do uso deoxicólico, nenhum comportamento anormal de enzimas canaliculares, mantendo as enzimas hepatocelulares normais e o fibroscan mostrando uma melhora com fibrose 2, sem gordura, e o ultrassom também, só uma leve heterogeneidade hepática, sem hipertensão portátil. E o que vem a discussão? Quais são as dificuldades na padronização dos autoanticorpos, que a gente vê que nessa paciente teve um padrão descrito, depois não teve mais, isso é o nosso dia a dia. Segunda pergunta, se o score diagnóstico sem biópsia se ajuda ou atrapalha, já que o score diagnóstico já pontua bastante só por ser mulher, por não ter álcool, não ter vírus, etc. Como que a gente define recaída em 2020? Se o critério bioquímico é suficiente para a gente lançar mão de ajuste de imunossupressores, já que pode ser confundido com várias outras nuances. E como que a gente deve estratificar o uso de terapias de segunda e terceira linha na hepatite autoimune. Obrigada.
So, hi everybody. Let's put this case into the context of the presentation of Dr. Henegan, who addressed the key points in the management of autoimmune hepatitis. I think that this case is very interesting because it addresses the kind of autoimmune hepatitis that we see in Brazil that affects mostly young girls. Eduardo can highlight this, but in the cohort of São Paulo, the mean age of presentations for type 1 autoimmune hepatitis is really 16 or 18. It's a disease almost in the pediatric range here in Brazil and more aggressive. I think that this patient, Liliana, never attained remission. Since you saw her at first, liver enzymes were always above the upper limit of normal. And I think that remission, and then liver enzymes were in subsequent visits above the upper limit of normal. In young girls, adherence is always an issue. I think that maybe she was not taking adequately her pills, because in this age, it's very difficult for girls to use prednisolone or prednisone. So adherence is an issue, but I think that with the change to mycophenolate, it was possible to attain remission at last. It's more difficult to see this picture in those patients with incomplete or non-response, as addressed by Dr. Henegan. But this patient, I think that with mycophenolate and maybe more strict adherence, She attained remission and also some reversal of fibrosis on the last liver biopsy and the last fibroscan examination. I will pass for Dr. Eduardo Cançado for his comments and maybe raise some questions from the audience. But Eduardo, please, you can comment the case and also discuss a little bit about the picture of autoimmune hepatitis in Brazil.
Yes, we do.
It's a very classical case of autoimmune hepatitis in Brazil. Young girls with the most frequent marker is muscle antibodies with the classical pattern. Is a pattern who lead us to think in antimicrofilament antibody, anti-actin antibody, because the pattern, the reactivity in smooth muscle, vessels, glomeruli, and fibrils inside the tubular cells. The treatment is classical azathioprine and prednisone, but I think this patient has had several relapses. Maybe she was not using properly the medication, or sometimes the doctor didn't wait for a long time, 1 year, 2 years, with the normal aminotransferase levels to reduce the dosage. I think she had a good response, but she had several relapses. Usually we need to wait at least 24 months with normal aminotransferase, and if you have also normal IgG, is the conception, our conception for biochemical remission. And Paulo highlighted this patient never had a complete remission. She neither biochemical remission.
Oh, she did it.
I think mycophenolate could be used in this case, but I think this patient had a good response to azathioprine, but it's an option. In Brazil, you cannot use second line and third line therapy. We don't have neither mycophenolate nor tacrolimus to treat our patients with autoimmune hepatitis, only in private clinics or for special case. The public health, I cannot prescribe these drugs.
Eu gostaria Dvora, de voltar para as perguntas de Liliane e para o Michael. Michael, can you answer from the questions, very interesting questions from their case that Dr. Liliana Mendes asked to us. And also there is a few questions from Q&A that can you ask you and for the debate as well. Please.
Okay. So there were, I think, 4 questions. I think Eduardo has talked about the antibodies. Of course, 20% of patients will have undetectable autoantibodies. A significant proportion of patients will have relatively normal IgG. In truth, in managing patients, at least in Europe, whether or not you are antibody positive or antibody negative, it doesn't really make any difference because the paradigms of treatment are exactly the same. I think it has been discussed that adherence has to be the #1 consideration for this patient, and it really brings into focus how we use corticosteroids in young patients. All patients hate steroids, and actually budesonide, I think, for non-cirrhotic patients and for young patients, it avoids the weight gain and it avoids the cosmetic effects. I think that is important. The elevation of AST and ALT above twice the upper limit of normal. There is a consensus statement being generated by the International Autoimmune Hepatitis Group that actually what we really need to be aiming for is normal AST, ALT, and normal IgG. And I believe that that is probably a better mechanism for us. Optimizing thiopurine therapy is the most important thing you can do for patients, and having an attention to if you can measure metabolites and getting the ratio of 6-methylmercaptopurine and 6-thioguanine in an appropriate range is probably as important as anything else. The amount of patients who need tacrolimus, if adherence is good, is actually quite low. I have forgotten what the fourth question was, but I think it was in relation to second and third line therapy.
Leila? Posso falar uma pergunta da Débora?
Sim, pode falar.
Please, Professor Michael, do you think the liver biopsy is essential to confirm histology remission?
I believe that liver biopsy is important if you are considering withdrawing treatment. I think it is absolutely critical in that setting. Whether or not we have to be repeating liver biopsies every 2 or 3 years, we don't necessarily have to be doing that. And I think that liver biopsy should only be reserved for confirming that concept of complete remission, where you want a hepatic activity index less than 3, normal IgG, normal AST, and then thinking about withdrawing treatment completely. I think that many patients can be managed without liver biopsy. That is not necessarily what some of the International Autoimmune Hepatitis Group would want to hear. But actually, when you have a patient like the patient described in the case, this is a patient that we know responded nicely to corticosteroids. Of course, the issue is getting her to continue to take the treatment.
There are 3 questions.
Michael.
Yes?
Budesonide, I think budesonide is interesting, but the papers comparing budesonide and prednisone in inflammatory bowel diseases is 9 milligrams correspond 40 milligrams. I think the paper, the study of Michael Mans, this comparison 9 milligrams against 40 milligrams, I think the results favor budesonide. Don't you think so?
I think they favor budesonide, and of course it was a composite endpoint of side effects and biochemistry. It was not just one, it was a composite endpoint, not just the endpoint of biochemistry. But what I would say is that even increasingly patients are, they're well read, they understand the choices that they have. Budesonide is not for everyone. I think it is for people who have less active disease. It also takes much longer for it to have its effect. Certainly, that's my experience with it in a number of patients. It is safe, but ultimately, even lowish doses of budesonide are associated with the same steroid side effects long term, other than perhaps the weight gain. They get the cataracts, they get the bone loss, they get all the same side effects. And you're right, the equivalent dosing is quite frightening. Of course, what we really want is to be able to taper the budesonide. Nobody quite knows how to stop budesonide, and these are some of the challenges that we have.
There are 4 questions. May I pose the questions?
Yeah, sure.
So what do you do when you find in liver biopsy in people with normal liver enzymes, histological activity. It's time to withdraw therapy, but on histology there is a histological activity. What do you do regarding immunosuppression? It's the first question. The second is, in this case, would prefer tacrolimus over mycophenolate, the second question. And the third and last question from the audience, what are the options that you do suggest for cirrhotic patients with autoimmune hepatitis in childbearing age to contraception?
Oh, three big questions. I think let's start with the cirrhosis and patients in childbearing age with contraception. I certainly have no problem recommending a coil as contraception for patients. It's safe, it's well tolerated, it's not associated with infection. I think low dose, there is of course a vogue amongst obstetricians to recommend a prednisolone only pill or a depot injection. That seems to work, or a low dose pill. I have not had any major problems with any of the approaches. Now, with regard to the first question, I've forgotten it already.
Remission, about the remission, histological remission.
Histological remission. So you have a patient who has completely normal enzymes, you do a liver biopsy, and then they have a hepatic activity index, let's say of 5 or 6. Of course, these are the patients that are more likely to relapse. Sometimes, if you're making a decision with a patient, the patient may want you to withdraw the treatment, and then you know that I would personally recommend, if they have active disease, that they stay on treatment, perhaps optimize azathioprine. But I think these are the patients, you stop the immunosuppression, you know they're going to relapse. So I would advise against that. With regard to other immunosuppression, I like tacrolimus. That's probably because I'm a transplant doctor. It's relatively easy. You can now get it once a day rather than twice a day. Run levels of somewhere between 4 and 6. And for most patients, it really works very well and it's well tolerated. Kidney function is preserved.
Michael, if the patient has a biochemical remission and the histology is not in remission, activity is more than 4, according to Jacques. What do you prefer, to increase the dose of prednisone or azathioprine, or to add tacrolimus?
I would prefer to optimize their current treatment, increase the azathioprine, but manage the patient based on their metabolites. There is, in inflammatory bowel disease, increasingly patients are being used with 100 milligrams of allopurinol with 25 milligrams of azathioprine to change the pathway of metabolism in these patients and get the more active metabolites. I increasingly like to use optimized thiopurine therapy, then think about steroids, then think about tacrolimus. That's my...
Okay. And when do you repeat the liver biopsy? 1 year, 12 months?
Think 12 months is about the right period of time, because it takes at least 6 months for the histology to follow the biochemistry.
What about the use of ursodeoxycholic acid in autoimmune hepatitis is another question.
So I think that when you have patients with cholestatic variants or elevated alk-phos and gamma-GT, urso certainly will do no harm whatsoever. I'm sure, Paulo, you must use urso occasionally, and of course patients don't mind it. What's your experience?
My experience, like yours. I don't see, for example, ursodeoxycholic acid as an option for initial treatment of autoimmune hepatitis, and only for those patients with variant forms, that treatment has to be individualized. But it was a question from the audience.
Yep.
Michael, many patients with autoimmune hepatitis, after the treatment, the gamma-GT, gamma-glutamyl transferase, start increasing. And in our hospital, you decide if the gamma-glutamyl transferase is more than 5 times the normal value, we start ursodesoxycholic, I asked.
So I think this is a really interesting phenomenon. Of course, let's take liver transplantation and somebody with acute rejection. You treat their AST and ALT. We follow their AST downwards, but we always know that many patients then begin to have a cholestatic phase where the gamma-GT remains high for a period of time. This is a phenomenon, I think, that is also very common, but not well reported in autoimmune hepatitis. It is not reported, but it is something that we see all the time in clinical practice.
Michael, there is 2 more questions because I know that I have to leave you there because as the audience have to know that today is a wedding birthday from Michael and he has to leave in soon. But I have more 2 questions here that's interesting for you. Do you believe that is your experience in concomitant autoimmune hepatitis with hepatitis C? Do you believe that ACV can be a trigger for autoimmune hepatitis? The question is from our colleagues, Rosângela Teixeira from Belo Horizonte.
I certainly have seen this in the past, but actually we're seeing this much less than we used to. Of course, it was much more common also when we were treating hepatitis C with interferon, but I've seen it. It doesn't happen too often, but I've certainly seen it.
Right. What do you think about azathioprine in the old people?
I think that the amount of azathioprine that you often need in older patients to maintain remission is actually much lower. I think it's well tolerated. I think I think if your goal is to try and minimize corticosteroids, minimize prednisolone, then I'm a big supporter of using azathioprine.
And I think for the last question for you is from Letícia Nabuco from Rio de Janeiro. She asked what is the histological criteria for stopping treatment? Absence of interface hepatitis, light interface hepatitis?
It's actually when you get your pathologist to calculate the activity, well, obviously no interface hepatitis, but you get your pathologist to calculate the activity and it has to be less than 4. Consider that 18 is the maximum score in HAI. It needs to be less than 4. So it is pretty minimal activity on biopsy.
Leila, I would like to ask a question to Michael. It could be? Michael, I think it's very interesting to see patients with high levels of aminotransferases and high levels of bilirubin have more chance to achieve biochemical remission. Do you have any explanation for this?
So my explanation for this is that these patients are typically non-cirrhotic. These are patients that have the capacity to regenerate. Whereas if you have patients with much lower levels of transaminases, the amount of liver that is available for regeneration and recovery, in my opinion, is much less.
Okay, Michael, I think I have to really have the last question because Gilda Porta is a pediatric, is our queen hepatology pediatric here.
I am now getting in danger of being divorced, Leila. So this is the last question.
For that reason, it says only 30 seconds to answer.
I have had 25 years of married life, which was
God bless for you.
The next 25 years. The next 25 may not be so happy if I don't turn up. So last question. Last question.
She asked if it's RMI, if you use the cholangio RMI in this patient, in this population.
Say that again.
Gilda asked if you're doing RMI, cholangio RMI in the patient.
Oh, MRI. Yes,
RMI,
MRI. We are doing MRI in all young patients, and Dr. Joshi, who is speaking next, is our PSC and AISC expert, and actually looks after the majority of the children that come through now in King's. What I think is also very interesting as a technology is going to be the Perspectum Diagnostics MRI technology. We have done a pilot study, and it seems to be very helpful in terms of at least correlating biochemical activity against the activity of the new MR technology. So I'd say watch this space. 15 years time, we won't be talking about liver biopsy anything nearly as much. It'll be about MRI with the activity, the ability to look at hepatic activity. But yes, the MRI for MRCP critical in young patients. Absolutely.
Okay, Michael, thank you very much indeed. Once again, happy birthday, wedding birthday. And I have to say to you that's more than 6 people is listening now. In the room is around 300 people. Okay, thank you very much indeed.
Thank you so much for thank you for
having me. Enjoy your day. Take care.
Thank you.
Many thanks.
And hopefully we will be back in Brazil soon again.
Sure, next year. That's
next year.
Hepato Pernambuco 25 years next year.
2021. We want to go to Fernando de la Noronha.
Great. Okay. Thank you, Mike.
Take care. Bye.
Bye-bye.
Bye-bye.
Now it's my great pleasure to introduce Dr. Deepak Joshi. It's my pleasure, Deepak Joshi, to have you here in Hepato Pernambuco 2020. It's for the first time. It's a pleasure to have you here. I hope that that's not the first, but you'll be more and more because you have a good relationship with our institute and King's College. Hopefully that you enjoy this webinar. You have a few colleagues here that I'd like to introduce you. It's Paulo Bittencourt and Eduardo Cançado. Their expertise in their autoimmune disease, hepatology disease. And also Cláudia Ivantes and Liliana also is expertise from our colleagues. And now Cláudia Ivantes, Dvora, will be introducing Cláudia to present the case report from PSC.
Ok, obrigada, Leila. Cláudia Ivantes, nossa querida colega do Paraná, vai apresentar um caso. Ela é mestre e doutora em Medicina Interna pela Universidade Federal do Paraná, professora substituta de gastro da Universidade do Paraná e médica do Serviço de Hepatologia e Transplante Hepático. Seja bem-vinda, Cláudia, então, para apresentar, após a apresentação do professor, o caso clínico.
Joshi, the presentation will be in Portuguese, but all the slides is in English, and we talk in English after that, okay?
First of all, thank you very much for the very kind invite, Leila, and all the organizing faculty. I'm hoping one day I will get to come to Brazil and present in person, and hopefully that may well be next year. So the topic is controversies in PSC. These are my disclosures. But I'd like to think that PSC is actually a very difficult disease to manage. The reason being there's a lot of different clinical phenotypes, and I'll allude to some of those phenotypes very shortly. Sometimes the diagnosis is not always straightforward. There can be overlap syndromes with autoimmune hepatitis. There can be other diseases, other cholangiopathies, which can mimic primary sclerosing cholangitis. I think also what's always concerning if you look after these patients is that it's a very high cancer risk, not just HPB malignancies, but also sort of colonic or GI malignancies, which can be difficult to diagnose. At present, I'd like to think there's no effective treatments, and maybe that will come out in the discussion. And unfortunately, even though we have liver transplantation and it is a good modality, a good treatment option, it does reoccur. 20% of patients can have evidence of a recurrent cholangiopathy after 5 years. So it does make it very difficult. So just touching on the pathogenesis very quickly, this is sort of the natural history of PSC. Initially, you have sort of very minimal sort of epithelial changes, very few lymphocytes around, but then over a period of time, you get sort of obliterative, non-suppurative cholangitis, and you get this periductal fibrosis, sort of classical onion skin appearance that one can sometimes see on biopsy. And then the worry is that with some patients, unfortunately, that with this ongoing inflammation, they will go on to develop dysplasia, and then obviously the worrying cholangiocarcinoma as well. And that can be the natural history in some of our patients. So this is what people think PSC is. It's one disease, but actually I'd like to introduce this sort of concept of PSC subtypes. So there are patients who have PSC with inflammatory bowel disease, and we all know the important role of having good control of their inflammatory bowel disease has on the outcome of their PSC. There's a number of papers which have been recently published in gastroenterology which show the huge impact of IBD on PSC, and that patients with PSC IBD have an inferior outcome to IBD or PSC alone. You have small duct PSC, which perhaps has the best prognosis going forward. And then you have overlap syndromes with autoimmune hepatitis. Some people believe in PSC, PBC overlap, and certainly there are a number of cases out there. And then there are patients with PSC who go on to develop cholangiocarcinoma. And again, their treatment options can be very limited. You're thinking about potentially resection or surgical options. And although there are certain units around the world which offer liver transplantation in, again, select group of patients. If you measure IgG4 levels in patients with autoimmune liver disease, PSC, even PBC, you can find raised serum IgG4 levels. Now, this does not mean that they have IgG4 related disease, but looking at a subgroup of PSC patients with raised IgG4 levels, they can again have a more aggressive disease and can have a more sort of quicker, disease progression, certainly needing liver transplantation. And then lastly, you can have large duct PSC. So I think we need to be more sophisticated. We need to be more nuanced. We need to describe these sort of phenotypes which help us understand the patient that we're looking after. This is data taken from the International PSC Group, again looking at the different sort of subtypes of PSC. Small duct PSC appears to have the best sort of outcomes compared to overlap or classical large duct PSC. And then there are, when they stratified according to age, those that are younger have a sort of a greater sort of liver transplant-free survival compared to those patients who are older. Crohn's disease appears to have a better outcome than ulcerative colitis or indeterminate colitis, and this disease affects has a worse outcome in men more than women. So these are the controversies in PSC, I think, as we stand in 2020, making the correct diagnosis. Some people will perform a liver biopsy, others will go on MRCP and cholangiography alone. At present, we don't have sort of robust predictors of disease. Now, we will look at the alkaline phosphatase, but some of the clinical trials which are now being performed don't always tell us that alkaline phosphatase is a true predictor of disease or the sort of disease progression as it is in PBC. There are a number of sort of scoring systems, from the Mayo PSC scoring system to the UK PSC scoring system. And again, it's about finding a sensitive and robust predictor which we can tell our patients what their outcomes are likely to be. The role of IBD I've already highlighted, and I can't highlight that enough. You really need to work, if you're a hepatologist, then you have to work very closely with your gastroenterologists in managing these patients' IBD. Medical therapy, again, this may come out in the debate, the role of ursodeoxycholic acid. and whether we should give it to our patients. But we do know that at present, the data suggests that it does not affect or improve the natural history of the disease. There are a number of clinical studies. Beta-cholic acid has now been used in a sort of phase 3 study. There's a number of phase 2 and phase 3 studies looking at FXR agonists also, which may have some sort of positive outcomes. And there's also norursodeoxycholic acid as well, which is being trialed. There's the endoscopic management, and then there's the role of liver transplantation. And as I said before, it does return. So picking, obviously 20 minutes is not a long time. So I've gone with the endoscopic management. This is a topic very close to my heart. I practice ERCP, and it has a key role in the management of patients with PSC. So I have a case which will illustrate some of the issues involved, and it may help bring out sort of the discussion points. So SB is a 39-year-old female. She's known to have ulcerative colitis, was diagnosed early in her early 20s as a pancolitis, and is on a 5-ASA and it's Octasa that she appears to be on. 4 years later, after her diagnosis of ulcerative colitis, she was diagnosed on MRCP with PSC, and she is on ursodeoxycholic acid. So the clinical scenario is that she gets increasing pruritus, increasing itch, increasing cholestasis, and you can see her labs here. These are her previous labs, and she's jaundiced as well. And if you believe in CA19-9 as a marker of cholangiocarcinoma, it was 150, and that is raised. So this is her cholangiogram, her MRCP. You can see the big gallbladder, which is sometimes associated in patients with PSC. You have your dilated intrahepatics here, more so on the left side, and we can't quite appreciate the sort of common hepatic duct, but here there's a suggestion of a dominant stricture, and obviously with upstream dilatation in the context of pruritus and cholestasis. So the next step here, I think we would all agree, we need to intervene here, and it is an ERCP that the patient will need. So just a little bit about ERCP. Certainly now it's a therapeutic modality, it's not diagnostic. I think in children it's very different, and we still perform diagnostic ERCPs in small children because MRCP is just not sensitive enough. But for the time being, for PSC, our first step is always MRCP. It's important to add that ERCP in patients with PSC, there is an increased risk of complications. In the audience, those who perform ERCP will know that sometimes the papilla can be smaller, it can be slightly retracted. And when you're performing ERCP, really it should be performed by somebody who's experienced in these cases. There's an increased risk of pancreatitis, cholangitis as well. And these are the EASL guidelines, the European guidelines, saying that really the recommendation is that it should be an experienced endoscopist due to sometimes the technical difficulties of getting in and out of strictures and treating them also. So there's very few absolutes in medicine, but I think this is something we can all take away. For patients who are having ERCP and PSC, they should all get prophylactic antibiotics, and this is recommended by EASL. So what we tend to do is give a dose procedure and then 2 doses afterwards of intravenous antibiotics, and then depending on the sort of extent of the cholangiopathy, we will give antibiotics for up to maybe 5 days orally on discharge. So these are the indications, so why we need to intervene. A lot of the time, the commonest indication is a dominant stricture, and I will show you what the definition of a dominant stricture is very shortly. They are at increased risk of developing gallstones or stones within the duct, and again, it's a common finding at the time of ERCP, and very rarely we do sometimes insert nasobiliary drains for severe pruritus, trying to break the enterohepatic sort of circulation, but this is quite rare. So these again are the guidelines. ERCP should be considered when there's worsening symptoms, if there's increasing cholestasis, or there's a new dominant stricture. And these are the recommendations of the European sort of guidelines, and these are the British guidelines, again, saying that it should be discussed in a multidisciplinary team meeting and make sure that the ERCP is the right thing for that patient. So these are the definitions of a dominant stricture. So in the common hepatic duct or the common bile duct, then it's less than 1.5 millimeters, and whilst in the intrahepatic ducts, it's less than 1. And you can see here on the cholangiogram, which is circled, you can see there's a dominant stricture there with dilatation above. But being practical, surely a dominant stricture is any new narrowing in a patient who has increasing cholestasis or worsening symptoms. So I don't think many people go by this alone. And I know that the International PSC group, we are debating currently what a definition of a dominant stricture is, and that debate is ongoing, and I think it's been ongoing for 2 years. So there's a lot of discrepancy between what people think. But what I want you to do now, I want you to think about an alternative reality for this patient. So this is the patient's MRCP at diagnosis. So when she was 28, this was her MRCP. So you can see big gallbladder again. You can see beautifully the common bile duct, the common hepatic duct. There is a peripheral cholangiopathy, but certainly no dominant stricture here in the left main duct or the right main duct. And the reason I want to show you this is because the way PSC is managed endoscopically in the United Kingdom, certainly in Europe, and I'd be glad to listen what people do in Brazil, is that patients don't get an ERCP unless there is a change in their symptoms or a new dominant stricture. But this is a paper from the Heidelberg group in Germany. And actually they came, this is data from across 30 years published in Gut just last year. And they looked at this in a very different way. And actually what they did is all patients within their unit, I think this is going back to 1987, were put into either a scheduled ERCP group or on-demand group. So essentially patients who were in the scheduled group, they had ERCPs at yearly intervals. So this is a significant amount of endoscopy, which could be high risk potentially, but they had ERCPs at yearly intervals. And if they had a dominant stricture, so this is at the time of the ERCP, then they went on to have treatment, and treatment was predominantly with endoscopic dilatation. So this is very different to how we manage our patients. And this is their results essentially. So in the end, they had nearly 300 patients, those who had the scheduled sort of protocol ERCPs. And if you like, the on-demand is what we do certainly in Europe and the United Kingdom. And what you can see is these patients, they had less number of deaths compared to the sort of on-demand group. And also they had less number of cases with cholangiocarcinoma. Now, if I show you their Kaplan-Meier's, and this is where it gets very interesting, is that in terms of transplantation-free survival, the scheduled group, the red group, had better outcomes, statistical outcomes, compared to the on-demand group. And then when you broke it down into those who had a dominant stricture, again, there were better outcomes in the scheduled group compared to the on-demand group. In their sort of multivariate analysis of sort of risk factors for having either early death or going on to develop sort of more complications, the presence of a dominant stricture was statistically significant. And also what was interesting, that if they did not adhere to the sort of scheduled ERCP group, then they were also more likely to run into trouble, again statistically significant. So this is very different to what we do around the world, but maybe the reason the authors think they had a better outcome in the scheduled group is that they were more likely to intervene on sort of strictures with cholestasis early, so there's less likely to have a biliary type injury, have progressive liver disease. And in theory, although they didn't show it, they were saying that maybe patients were less likely to develop cholangiocarcinoma, but they didn't quite show that in their results. So Michael mentioned this a little bit. This may be something we use more and more of in the future. This is quantitative MRCP. So what this sort of software can now do is tell you how narrow these strictures are. And this might be a very good way of monitoring patients from simply MRCP alone. You you can measure the stricture diameter and map it potentially going forward. So this is produced by Participaram Diagnostics, and this may be future technology we use. So this is the patient's ERCP. You can see here the dilated left main, the sort of common bile duct and the common hepatic duct don't appear to be so diseased. And we went on to brush this and dilate it. I think, we know that there's increased risk of cancer in this group of patients. And it's interesting that 25% are diagnosed within the first year of diagnosis. And like I said, there's a risk of gallbladder cancer. And if you have IBD, that also there's a risk of colorectal cancer. Again, taken from the International PSC group, this risk of cancer increases over a period of time. And again, the risk of HPV malignancy is greatest in your classical large duct PSC compared to small duct or your overlap, according to these data. So if you find the stricture, you have to sort of work out what you're going to do with it. And I'd like to introduce this concept of a AAA or the 3A approach. It's about accessing the stricture, assessing the stricture, and then actioning the stricture as well. So again, those of you who do ERCP in the audience, there's a variety of guide wires, a variety of cannulae, but you have to feel comfortable. And I think now we are becoming more like interventional radiologists. We are using talking devices to guide, the guide wire into specific ducts and access specific strictures. So again, have your go-to wire and be comfortable with it. In terms of assessment, brushings, we all will do. Biopsies can be targeted or non-targeted. And there's the availability of fish in certain centers, although the availability is not great. And there's an increasing role of cholangioscopy. I think it's fair to say that brush cytology in the large majority of cases is not enough, and you need to combine it. FISH does increase the sensitivity of detecting cholangiocarcinoma, and again, if you add biopsy in as well, it improves your sort of sensitivity of diagnosis. And these again are the sort of guidelines from EASL. Again, it just tells us we need to combine our testing. One brush is usually not enough. Certainly if you have a high risk or high suspicion of cancer, you have to go back either again or combine your modalities. And these are some of the sort of sensitivities and specificities you can achieve potentially if you combine cytology, intraductal biopsy, and FISH analysis as well. So it can improve your outcomes. So what about the role of cholangioscopy? So there's diagnostic. The stricture evaluation is probably the majority of cases we use, and we can help map as well. So if there is a malignancy, we can sort of measure out distances for our HPV surgeons. There's therapeutic intent as well, predominantly with stones. You can use sort of lithotripsy or laser, and then also migrated stents as well, which we can now fish out if they get stuck. So I think for cholangioscopy and PSC, we're trying to become like sort of colonoscopists. We're trying to make visual diagnoses, looking at areas. But although there is increasing number of data being produced, I don't think we're at a point yet when we can look at a stricture or the mucosa and say, is this cancer or not? So we need targeted biopsies. And I think the yield of biopsy is much better. We have sort of bigger biopsy forceps, which are passed down the cholangioscope, which allow us to take a bigger sample. The areas we look at, sometimes they can be increased sort of vascular pattern. There can be these projections which look abnormal, but again, we need to take tissue to make the diagnosis. Something which we're seeing of more and more at the time of cholangioscopy in patients with PSC is that although we think this could be sort of a dominant stricture, could be malignancy, we're finding that a lot of the time that there's due to stones, sort of microlithosis, which you cannot appreciate on EUS or on MRCP, and it's only at the time of the cholangioscopy that you appreciate it. So if we see a stricture, should we dilate with a balloon or should we stent? I think the way it is at present in 2020, data from the DIL-STENT 2 study, so this was a multi-site study, and it looked at the role of dilating or stenting alone, and the outcomes seem to be similar in terms of resolution of stricture. But what was interesting was that the group that got the stenting, they appeared to have more number of sort of side effects, and in particular pancreatitis, and these were statistically significant. With stenting and certainly with dilatation alone, there was improvement in pruritus, improvement in cholestasis. But one caveat I think we need to think about is certainly that patients with advanced liver disease, so Charles-Pugh scores of greater than 8, were excluded. And I suppose what we don't know whether this is the same for patients with advanced disease, or do they benefit from a stent? So we wait to see new data on that. So this is stricture action over a period of time. You can see a dominant stricture here in the common hepatic duct, balloon dilatation, and this is the resolution afterwards. So great improvement. There's a number of different types of stents. If you want a stent one can use, you can have straight plastic stents, you have double pigtails, you have fully covered stents, you have intraductal stents now, which we can deploy, and these are the removable threads which we can then leave in the duodenum and then remove. And what's very interesting is now the availability of biodegradable stents. So you can place these stents in theory into the duct, and they biodegrade over a period of time, whether it's a week or 12 weeks. So we wait to see where this technology fits in the future as well. So this is back to the patient. She had brushings. They were reactive cells, no malignancy that our histopathologists could see, but we were concerned there was weight loss. The CA99 had gone up. So we went on to perform cholangioscopy, and this is the patient's cholangioscopy, and I hope this works. There we go. So here you can see the retracted papilla. We have a guide wire in, and this is the intraductal view of her common bile duct. You can see the pseudopapillae, the abnormal mucosa of the common bile duct. And we're going along, it's a wire-guided cholangioscope. And you can see here on the cholangiogram on the left, we're just here at the origin of the left side. And the mucosa here, although the cholangiogram looks very abnormal, here the mucosa looks very normal. So in this case, we just performed sort of a diagnostic cholangioscopy. We didn't take any biopsies. We didn't do any brushings. You can see the mucosa was reassuring here. And I think this is another role of cholangioscopy, although the cholangiograms can look very abnormal on MR or even on ERCP. This is reassuring. So here we felt reassured that there was no malignancy that we could see within the duct anyway. So unfortunately, she did develop cholangitis post the cholangioscopy and needed to stay in hospital for a further 3 days, but she recovered and her cholestasis improved. We were concerned about malignancy, so we went on to do a PET scan, which was negative. And I suppose the worry in this young lady, young adult, is that whether she will go on to develop a malignancy at some point. So there's ongoing surveillance. And again, we can debate what surveillance we should do in these patients because there are no guidelines that recommend any surveillance. So this is my last slide. So hopefully I've shown to you the crucial role of ERCP in patients with PSC. And I've shown you an alternative reality or an alternative way of looking at our patients. Should we be doing scheduled ERCPs every year, or should we be doing on-demand ERCPs as we're doing at the moment? There's the AAA sort of thought process of access or assessment and action, and this should be every time they're having an ERCP. And I think at present we're looking more at dilating strictures than stenting, although the data is not there in patients with advanced liver disease, and we wait to see this data. And there's an increasing role of cholangioscopy in not just making a visual diagnosis, but also help target biopsies, provide targeted biopsies and help improve the diagnosis. So I'd like to thank you for your attention, and I'd be delighted to discuss further cases and take your questions. Thank you.
Thank you very much, George. Excellent presentation. It's very nice to see ERCP as well. There is some endoscopy like Dr. Paulo Bittencourt could be discussed with you as well. And Dvora, I think you introduced Cláudia to present the case, the experts. After that, you'll be discussing the questions.
Dear Dr. Cláudia Ivantes, please beginning your case, clinical case, please.
Bom, vamos lá. Muitas das questões já foram respondidas ou discutidas na aula, mas eu procurei trazer um caso cheio de dúvidas. E é uma paciente, então, de 17 anos, que 2 anos e meio antes ela iniciou com um quadro cutâneo de prurido, dor nas articulações, em especial nos joelhos. Essa dor era tão intensa que por alguns períodos a impediu de deambular, e ela não chegou, não teve nenhum diagnóstico. Mas 10 meses antes, ela começou a apresentar diarreia com sangue e dor abdominal, quando ela visitou um outro colega que a submeteu ao exame de colonoscopia, onde foi feito o diagnóstico de retocolite ulcerativa e uma colangiorressonância com diagnóstico de colangite esclerosante primária. O colega iniciou, então, ácido ursodeoxicólico numa dose bastante baixa e prednisona associada à mesalazina para tratamento da colite ulcerativa. Aí ele iniciou com a dose de 40 miligramas, mas já tinha orientado que a paciente reduzisse a dose para 30. Além disso, cálcio e vitamina D. Então, essa é a primeira consulta da paciente comigo, no meu grupo, e ela vinha, então, com transaminases bastante alteradas, fosfatase alcalina também elevada, gama-GT alterado, bilirrubinas normais, o IgG um pouquinho alterado, ANCA-P positivo, FAN negativo e um CA19,9 de 10. Nessa ocasião, então, eu fiz um ajuste da dose do ácido ursodeoxicólico para 15 miligramas por quilo por dia e associei, então, colestiramina para tratamento do prurido. E um mês depois, ela veio com os exames com uma melhora bastante significativa. Ela estava, então, acompanhando da parte intestinal com outro colega gastroenterologista, que estava em esquema de retirada do corticoide e introduziu a azatioprina na dose de 50 miligramas por dia, mas com o objetivo de progredir até 175 miligramas por dia. Em setembro, então, do mesmo ano, ela já sem o uso do corticoide, ela vem novamente com aumento de transaminases, fosfatase alcalina e gama-GT. A minha primeira pergunta, e depois eu vou repeti-las no final, é para uma paciente que já vem em uso de imunossupressor pela doença intestinal, seria útil eu realizar uma biópsia hepática para afastar a colangite esclerosante primária, de colangite esclerosante primária associada à hepatite autoimune? Bom, acreditando que havia também, então, um componente de hepatite autoimune, nós reintroduzimos prednisona na dose de 20 miligramas e mantivemos azatioprina para essa paciente. E ela teve uma piora do prurido e nós optamos, então, por suspender a colestiramina e entrar com rifampicina na dose de 300 miligramas por dia. E esses são os exames evolutivos dela, ela se manteve mais ou menos assim até 2017, mas com um aumento mais significativo do CA19,9, que não era no padrão que a paciente apresentava anteriormente. Nessa ocasião, ela estava em uso de corticoide ainda, mas numa dose baixa, ácido ursodeoxicólico, rifampicina para o prurido e azatioprina. Nós ficamos, então, mais preocupados e repetimos a colangiorressonância da paciente, que tem achados bem característicos da colangite esclerosante primária, mas tem uma área de estenose de extensão de aproximadamente 2 centímetros do ducto hepático comum. Além disso, nesse exame, a paciente já apresentava um fígado lobular com fissuras mais proeminentes e hepatomegalia, e esplenomegalia, perdão, que sugeriam que ela tivesse evoluído para uma doença hepática mais avançada, com uma fibrose mais avançada. As minhas outras perguntas são: como fazer diagnóstico de colangiocarcinoma precoce nessa paciente? Se os senhores se sentem confortáveis em seguir a paciente apenas com a colangiorressonância. E nós, então, aumentamos a dose do ácido ursodeoxicólico, mantivemos rifampicina, aumentamos prednisona e houve uma melhora, então, dos exames da paciente, mas do CA19,9, o que me deixou um pouco mais tranquila. E, na sequência, então, nós já fizemos uma colangioendoscópica retrógrada. E aqui os senhores podem ver uma área de estenose nessa imagem. Na sequência, eu vou mostrar esse videozinho aqui também. Foi feita uma coledoscopia, onde se vê uma área esbranquiçada, endurecida, mas sem neovascularização. O colega que fez o exame teve a impressão de que fosse apenas inflamatório, mas ele realizou inúmeras biópsias dessa área. E as biópsias mostraram apenas inflamação crônica. Só mais um pouquinho, o vídeo já termina. Ok. Na sequência, então, foi feita uma dilatação com balão. E embora nós façamos de rotina o antibiótico profilático, o colega ficou com receio de que ela fizesse um quadro de colangite e colocou também uma prótese. E a outra pergunta, isso também já foi discutido na aula do professor Joshi, com relação ao balão ou a colocação de stent. Qual seria a melhor opção de tratamento para as áreas de estenose? Essa paciente, então, esses são os últimos exames que eu tenho da mesma, com as transaminases um pouco mais baixas, mas não ainda dentro da normalidade, fosfatase alcalina ainda um pouco alterado, gama GT e bilirrubina de 2,12. Eu decidi, então, uma mudança de conduta em relação ao quadro imunológico da paciente e optei por introduzir ciclosporina junto à azatioprina e prednisona. Ela já estava usando corticoide por longos períodos, embora em alguns períodos apenas com 5 miligramas, e nós associamos também o bezafibrato. E ao associar o bezafibrato, ela apresentou uma melhora completa do prurido e a própria paciente interrompeu o uso, então, da rifampicina. E esses, então, são os últimos exames que eu tenho dela agora. Então, as minhas perguntas são com relação à biópsia hepática numa paciente que já está em uso de imunossupressor, como fazer o diagnóstico de colangiocarcinoma precoce nesses casos, se os senhores se sentem confortáveis em acompanhar a paciente só com uma colangiorressonância, para estenoses dominantes, a dilatação com balão ou a colocação do stent, e qual seria o papel do bezafibrato no tratamento da colangite esclerosante primária. Muito obrigada. Eu acho que agora os debatedores podem assumir.
Por favor, professor Paulo, professor Eduardo, por gentileza.
Bom, the first question about liver biopsy. I think this patient, I need to know how was the biliary tree. If there was dilatation, a diffuse dilatation in biliary tree, I will have fear to perform a liver biopsy. But this patient, I would like to know about the reactivity about anti-smooth muscle antibody. I have some patients with similar clinical picture, and they have also smooth muscle antibody. I think. Okay. I would like. I think liver biopsy should be a good idea for this case.
Okay, the antibodies were negative, all of them, and the at cholangiography the aspect was from PSC, classic PSC.
Do you think it was dangerous to perform a liver biopsy?
Yes, yes.
It was dangerous, yes. Because there is a classical case of PSC, but young female with very high levels of aminotransferases.
Exactly.
Yeah. I don't know if the improvement of liver, the biochemical, is only for also. I think corticosteroid could have had an action, a favorable function, a favorable action to treat a component of autoimmune hepatitis.
Yeah, I agree with you, and that's my question, if the biopsy is important or not at this time, because she's on immunosuppression.
Usually, when I start corticosteroid or azathioprine before performing liver biopsy, I wait at maximum 6 months.
Okay.
Okay, 3 months. Frequently interface hepatitis, rosette, usually persist after 3 months. The plasmacyte reduce after the starting treatment, but interface hepatitis and rosettes continue even longer.
Mm-hmm.
Let me give my opinion and turn the questions also to our international speaker. I think that liver biopsy would be interesting because this patient had, I think, more than 10 times an elevation of AST and ALT, I think. Maybe under immunosuppression with corticosteroids for inflammatory bowel disease. But I'd like to know the opinion of Dr. Joshi, and also ask him what is his opinion concerning treatment with UDCA in those patients with PSC. I know it's not evidence-based, but if he would introduce UDCA in these patients.
Thank you, Paulo. I think the question of liver biopsy here is very interesting. She's already on immunosuppression for her colitis, but like Eduardo said, the transaminases were so high, it makes you think whether there could be a potential overlap. Now, if I give some experience from here at King's, we have a large cohort of patients with autoimmune liver disease, autoimmune hepatitis, come from the pediatric side, and all patients with autoimmune hepatitis have a MRCP, and from this there's been the sort of development of terminology of autoimmune sclerosing cholangitis, and given that this is a young adult, we would have a very high suspicion of potentially having an overlap syndrome. I think the diffuse changes on the classical MRCP as described by Claudia, makes liver biopsy slightly higher risk, but I suppose you just have to put it into the context of the patient. Now, the autoantibodies could be negative because they're on immunosuppression. So I think this is a very good case and highlights some of the sort of tough decisions to make. I think your question, Paulo, of ursodeoxycholic acid, it's the data doesn't support any change in the natural history of the disease. I still prescribe it. I would prescribe it at a maximum of 15 milligrams per kilogram. I think the data from the US saying that high dose urso was increased risk of colorectal cancer has put us away from 20 milligrams per kilogram for most patients. The only slight caveat now is that some of the clinical trials will accept patients on ursodeoxycholic acid and some won't. So when I see patients for the first time and we're making a new diagnosis, I will sort of see whether they have symptoms of pruritus, the degree of cholestasis, and then their eligibility potentially for a clinical trial. So I look at it in a multifaceted way, but I still think it does help patients with symptoms and it has a role to play. And just because the old studies don't show it any benefit, maybe those studies weren't powered well enough. So it depends on the individual.
Okay. Another question I think is from Claudia. How to really follow these patients for the risk for screening, not for diagnosis of early cholangiocarcinoma. Do you still ask for those useless tests like CA or CA99, or do you only rely on MRI?
So there are no sort of accepted or recommended guidelines or surveillance programs for cholangiocarcinoma. And I think, in this patient, she's 17 and her risk will probably be the highest. She'll be in the highest risk group because she's so young. So she'll have a very high lifetime risk. And if you look at her last ERCP, her cholangioscopy, it might be, it's abnormal. There's, inflammatory tissue, and surely at some point it will become dysplastic and then malignant. Now, I think using CA19-9 is good, or can have some role, I don't know, but there are certain patients who carry a mutation where it's not raised, the FUT3 mutation. So, what do you do in that group? Can you do an MRCP or every year on these patients? Again, I don't know. I think, these patients need really good clinical supervision. They need sort of regular interactions with their hepatologist, their gastroenterologist, make sure we're controlling their inflammatory bowel disease. The honest answer is I don't know, but I would be very worried for this patient long term, because what you don't want is for her to develop a cholangiocarcinoma and then potentially be ineligible for liver transplantation or something. So these patients keep me awake at night.
That's my case.
Josh, do you perform usually fish test when you do ERCP?
So we might have the availability of fish very shortly, but it's just not available. That's the problem. I think, the cholangioscopy Claudia showed for her patient, there's so much abnormal tissue. You can't, how many biopsies can you take? I think there are newer technologies like confocal laser endomicroscopy, which we might be able to pass down a cholangioscope and look at the areas, but these procedures will take a long time, and the bile duct still is a very sort of long area to examine, and it'd be very easy to miss. I know people are using PET more and more, but again, PET can sometimes not distinguish between inflammation, cholangitis, or malignancy. So again, it comes back to looking at the bile ducts, using cholangioscopy, and having a very low threshold if you're concerned about cancer, so of cholangiocarcinoma.
Excuse me, my expert debater. I have 5 minutes to finish. I have a few questions for Q&A as well. I'd like to keep more time, George, because it's an excellent discussion and excellent case, but I have to time it to finish.
Sure.
And there is 2 questions from Deborah from São Paulo, that she asked, what's the best cutoff value to suspect cholangiocarcinoma? And if you would like to know your opinion about fibrates to treat PSC, patients with dominant structures. And the last question for the audience here for Q&A is from Hugo Chenke from Porto Alegre. If really, when you use UDCA in the PSC?
So first question, I mean, there's no one test that one can use to try and sort of survey for cholangiocarcinoma. So I think if there is a big change in the CA19-9, if that's what you're measuring, then that should trigger, a round of investigations, CT, MRCP, and depending on what they show, maybe go on to perform ERCP. If there's a new dominant stricture, then, your suspicion is high. And then, you have to feel that you have truly assessed that stricture in a combination way, not just brushings alone, biopsy, looking at the lesion, cholangioscopy, etc. So I think it's just your clinical suspicion. I don't think a patient will ever sort of berate you or tell you off for your care or your concern. But obviously, if we miss a cancer, then that is a big thing, and your patient will never forgive you. So just if you feel there's a cancer and you're not happy with the investigations you perform, then keep looking and ask colleagues, etc. I think the role of fibrates in PSC, in the UK, there's hopefully going to be a multi-site study on the role of fibrates. Obviously, we've seen the beneficial effects of fibrates in PBC, so maybe this may have a role to play. Again, I use fibrates in PSC only at the moment for patients with severe pruritus, and I'll add that in as therapy for that. And I think ursodeoxycholic acid, again, you know, it depends if they've got significant cholestasis, pruritus, you can add it in, but you know, have an open discussion with your patient and say this may not change the outcome of your disease, the natural history. It may improve your liver biochemistry, but we know that an improvement in alkaline phosphatase does not always correspond with an improvement in the disease. And that's the problem with PSC. It's so difficult to assess the high risk of cancer, and it is very difficult in these young patients.
Paulo and Eduardo, do you have some few comments for the end here?
Yeah. Yes, I would like to ask Joshi about the use of calcineurin inhibitors in patients with inflammatory bowel disease. What do you think about this? Because this patient, there is add cyclosporine. What do you think about?
It's not something routinely we do. You know, I think for even fulminant colitis, IV cyclosporine has gone out of favor here in the UK. We would tend to use things like infliximab. You know, I think in this patient, in Claudia's patient, you know, good control of the inflammatory bowel disease is crucial for this patient. So thinking about vedolizumab potentially, or other sort of biologics, we need to think about this patient, but getting good control, because we know, you know, if this patient has transplantation, their inflammatory bowel disease will impact on their sort of liver graft as well. So it's really important, but we don't use cyclosporine, I have to say.
Paulo, anything else, Paulo, to comment before you?
Just, for endoscopic treatment of PSC, I think it's a good option, but we need to have expertise, not only in ERCP, but also in endoscopic treatment of PSC to really use this option in our patients. So I think that it is more reserved for some centers with expertise. That's all that I think that I would like to comment. But it's, of course, it's a very interesting option. We see the results in this case, and also some new data that was presented by Dr. Joshi. Thank you a lot for the invitation, and I will lead the final comments for you, Leila and Dvora.
Okay. Cláudia, do you have anything else? Because I think this is one important for us. Is what you think IgG4? What's your opinion in the?
She had IgG4 in normal value. It's okay for this case.
Can I just add?
Josh, yes, Josh, you have any experience with IgG4?
Inflammatory bowel disease in IgG4-related disease is very rare. IgG4 disease does not tend to affect sort of the mucosa like inflammatory bowel disease does. So I think it'd be very unlikely. And you've given her steroids, you've given her azathioprine. So, and if there's no improvement in the cholangiogram, I very much doubt this patient will have IgG4 disease.
Dvora?
Sim, eu quero agradecer mais uma vez, achei excelente os comentários e essa discussão. Isso que nós nem entramos ainda nas controvérsias quando tem uma doença metabólica associada, né? Nem deu tempo para discutir essas questões, mas eu acho que elas são muito pertinentes. Daqui para frente a gente vai ter ainda novos desafios nessas doenças. E foi excelente o encontro. Muito obrigada pela oportunidade mais uma vez e parabéns a todos que participaram.
Okay, Joshi, it's our great pleasure to have you here in Liver Talks, Hepato Pernambuco webinar. And I'd like to say thank you very much to all my friends, all my colleagues, and especially in this conference because you have tributes from Professor Roger Williams. And sorry, Eduardo, I forgot to say that you was one of the fellows for the King's College. You work with Diego Vergani and Georgina. I forgot to mention this, and also Eduardo Silva from our Brazilian Society. There is included for many others friends that visit King's College for short time, and especially in the transplant patients as well, because we have a exchange program with King's College for many years in the liver transplantation as well. And I say to thank you very much Nadio and all transplant team, and also thank you very much. See you soon on the next week of the last liver talks. And it'll be Ed Gunn and Muhammad Siddiq from the US. And it's very nice to see all my fellows, that we are fellows in King's for the same times as Ed Gunn, who is fellow with me in the time, and see you next time. We have 615 patients watching your talks and in the room, because you have to be close, because if not, there is many questions. Is nearly 300 in the room. Thank you very much. See you for the next.
Thank you. Take care.
Bye-bye.
Bye.
Thank you. Bye-bye.